Hello friends, I am Dr. Ajay Yadav. Hope you did very well in your exam. However, in anesthesia, I could just manage to get two questions, two recall questions only. I don't know whether questions were really less or a student couldn't recall, or questions were tough that they're not able to recall, or they were too easy that they're not able to recall. So anyway, I could just manage to get two questions that I'm going to discuss. Arrange the following according to the potency: methoxyfluorine, halothane, isofluorine, nitrous oxide. Methoxyfluorine, isofluorine, halothane, nitrous oxide. Methoxyfluorine, nitrous oxide, isofluorine, halothane. Halothane, isofluorine, nitrous oxide, methoxyfluorine. Two most important property of inhalation agents that we should know. One among this is potency, and potency, is determined by its MAC actually is an indicator of potency. MAC, that is a minimum alveolar concentration that is required to produce immobility in 50% of the subjects who have been given painful stimulus. So if you are checking in human beings, then skin incision is considered as a painful stimulus. But if you are checking rats or guinea pigs, then tail clamping is considered as painful stimulus. Uh, so it's very much clear from the definition that I told you: minimum concentration which produces effect in 50% of the effects. So this is standard MAC is called as MAC 50, but that is not sufficient. We want effect in almost say 100% of the patients. So therefore practically we go by MAC 95, which clearly shows that the minimum concentration which produces effect in at least 95% of the patients. And this MAC 95 is usually 1.3 times of MAC or 1.3 times of MAC 50. So it is very much clear from the definition that if an agent has less MAC, it will be more potent. Like for example, say there is one agent which produces X effect at 1%, and there is another agent which produces the same X effect at 2%. So which is more potent? Obviously this agent, which is producing X effect at 1%, while the second agent will produce the same effect at 2%. So this is more potent. Means lesser the MAC, more will be the potency. So overall lowest MAC is of methoxyfluorine. Lowest MAC is of methoxyfluorine, that is 0.16. So this is methoxyfluorine. So obviously methoxyfluorine will be most potent. However, methoxyfluorine is not used nowadays in clinical practice. It's an obsolete agent. So among the agents of the current used, the lowest MAC is of halothane. You need not remember MAC, but just to give an idea, 0.74 means methoxyfluorine at 0.16% will produce effect in 50% of the individuals, while for halothane this concentration required is 0.74. Fine. So among the agents of the current use, halothane is the most potent, but overall methoxyfluorine. Now least potent. Now there are two things when you define inhalation agents, and that is actually a little confusion also, I will say. Inhalation agents are broadly classified as gaseous agents and volatile agents, and your gaseous agents are nitrous oxide and xenon. Other, that is halothane, isofluorine, desfluorine, sevofluorine, or other agents, older agents like methoxyfluorine, ether, they are inhalation agents but subclassified as volatile agents. So among volatile agents, least potent is desfluorine with the MAC of 6%. That means desflurane will need 6% to produce this effect, while methoxyflurane just at 0.16% produces this effect, and halothane at 0.74% produces this effect. So least potent volatile agent is desflurane. However, if you consider gases also, if you include gases also, then nitrous oxide is the least potent inhalation agent, and its MAC is actually 104%. That means it cannot act as a complete anesthetic. To produce its full effect, concentration required is 104%. So obviously it cannot provide alone as a full, cannot act as an anesthetic agent alone. That is why we use nitrous oxide along with one of our inhalation agent. So simply you can remember the most potent is methoxy overall. Among the agents of the common use, the most potent is halothane, and least potent volatile agent is desflurane, while overall the least potent inhalation agent is nitrous oxide. Now with this background, now again you can look at the choices. Most potent is methoxyflurane, A, B, C. So this automatically gets ruled out. Now least potent, you know, overall is nitrous oxide. So this choice also get ruled out. Now we have to consider between A and B. I told you among the agent of the current use, the most potent is halothane. So methoxyflurane, then halothane, then isoflurane, and then nitrous oxide. So A. Fine. And the second most important property other than potency about inhalation agent, which you have to remember, is blood gas coefficient. So blood gas coefficient or blood gas solubility, it is the indicator of induction and recovery. So very simple method to understand this is that if an agent is less soluble in blood, means if the agent's blood gas solubility is less, so it will be easy for brain to extract it from blood, so induction will be faster. So agent with the lower blood gas solubility will have fast induction, and that is why overall fastest induction and recovery is seen with xenon, but xenon is not yet available for clinical use. It is still in investigational stages. So among the agents of the current use, fastest induction and fastest recovery is seen with desflurane. And slowest induction and slowest recovery is seen with halothane. So these are the only two actually properties of inhalation agents which are often asked. So this you can see a screenshot of our eGurukul notes also, anesthesia notes, PGR, where we have discussed about this MAC. You can see I told you minimum concentration to produce immunity in 50% of the subjects, and that's MAC 50, MAC 95, and I told you most potent overall is methoxyflurane, while among the current use the most potent is halothane, and overall least potent is nitrous oxide, and least potent volatile agent is desflurane. So somehow you can say it's almost a direct question. Second question which I could manage to find is that which of the following local anesthetic causes hypertension? Lignocaine, cocaine, bupivacaine, and prilocaine. Cocaine. And this is one of the most important region which lead to obsolescence of cocaine from anesthetic practice. Otherwise, cocaine was the first local anesthetic used in clinical practice. And cocaine was such a potent vasoconstrictor that in fact there occurred some cardiac failure because of the cocaine. It produced so much vasoconstriction that increased so much afterload that actually led to cardiac failure. So cocaine was a very potent vasoconstrictor that leads to its obsolescence. So cocaine causes hypertension, while other local anesthetics at clinically used doses they are vasodilators. So I'll say all local anesthetics they are vasodilators except cocaine, which is a very potent vasoconstrictor, and other than cocaine, levobupivacaine and ropivacaine. They are also vasoconstrictors. However, their vasoconstriction is clinically insignificant. They produce, so they you know that levobupivacaine, ropivacaine are the isomers of bupivacaine, but bupivacaine is a vasodilator, while its isomers levobupivacaine and ropivacaine are vasoconstrictors. However, vasoconstriction produced by levobupivacaine and ropivacaine is clinically insignificant, but cocaine can cause significant vasoconstriction, leading to hypertension. And that's what you can see. That's again a screenshot of notes about cocaine. Two most important thing we have discussed is that the first local anesthetic, and secondly it is a very potent vasoconstrictor. So that also has been mentioned. So as I told you, I could manage to just find these two questions only, or I just a student sent me two questions only. Still, any of you, if you recall any of a question, you can send me. I will just go through my YouTube channel. If you have any doubt still, or any other question, if you can recall, you just let me know. I opened my chat. Any other question? I just wait for 1 or 2 minutes. Any other question? Any other question if you remember? Okay, I'm not seeing any questions. So should I close the session? So anyways, no problem. Later also, if you recall, you know that you can always connect with me on my Telegram group also, or you can post your queries on eGurukul also anytime. You're most welcome, and we'll try to solve as soon as possible. Avantika sir, how many correct responses is a good score this time? Avantika, exactly I won't be able to answer you this question because I really don't know the comparison that what kind of questions were there in other subjects. But soon I'll ask someone once they have compiled all questions. So someone from administration will definitely contact you. I'll forward your message to them. Okay then. Same question has asked. So uh, at a rate of medicine. So I just now told you that's not possible. Correctly, yeah, maybe right. This may be 140 plus. But exactly what kind of questions and what was the toughness level of the exam, that they'll be able to tell you, this administration people, once they've compiled the exam is full. Fine. Okay then. Thank you very much. And again, my best wishes. Hope you all will be coming with flying colors.